This PowerPoint will be reviewing the side effects of aromatase inhibitors, tamoxifen and raloxifene as part of the CREOG Video Project. The objectives will be to review and describe the indication for using aromatase inhibitors, tamoxifen and raloxifene, as well as understanding the side effects of these drugs. Before delving into the side effects of aromatase inhibitors, tamoxifen and raloxifene, we will describe briefly the indications for use, mainly being chemoprevention and adjuvant endocrine therapy. Chemoprevention is the primary prevention of cancer, specifically breast cancer, for tamoxifen and raloxifene. These drugs are FDA approved for use in prevention of breast cancer. There are various criteria that must be met, a few which are listed here. These include age greater than or equal to 35 and either a greater than 1.7% 5-year risk of breast cancer, or thoracic radiation prior to age 30, or atypical hyperplasia or history of lobular carcinoma in situ. Adjuvant endocrine therapy is recommended in those with hormone receptor positive breast cancer for at least 5 years. Tamoxifen or aromatase inhibitors are used for adjuvant endocrine therapy. Improvements are seen in risk of recurrence of breast cancer, development of secondary breast cancers, and overall survival. The approach for treatment depends on menopausal status. The average age of menopause is 51 years old. This is defined as no menstrual periods for greater than 12 months or more. In the context of this PowerPoint, this is also defined as no menstrual periods for greater than 12 months in the absence of tamoxifen, chemotherapy, or other ovarian suppression with a serum estradiol in the postmenopausal range. In the context of a patient taking tamoxifen, a patient may be amenorrheic and also be defined as being menopausal if their FSH and serum estradiol are in the postmenopausal range. Additionally, a patient may be iatrogenically postmenopausal if they've had a history of a bilateral oophorectomy. Aromatase inhibitors include medications such as anastrozole, letrozole, and exemestane. Aromatase inhibitors work by inhibiting the enzyme aromatase, thereby blocking the conversion of androgens to estrogens and decreasing serum levels of estrogen. Aromatase inhibitors are the preferred adjuvant endocrine therapy in postmenopausal women with breast cancer. It is important to know that these are contraindicated in those with preserved ovarian function. There are many side effects, but some are more commonly seen than others. Loss of bone density is one important side effect. Additionally, joint pain and stiffness is also seen. This can be treated either with exercise and NSAIDs, a temporary discontinuation of the medication, or initiating duloxetine. Additional side effects include sexual dysfunction and vasomotor symptoms. Tamoxifen is in the class of medications called selective estrogen receptor modulators, or SERMs. These work by competitive antagonism of estrogen receptors in the breast, thereby inhibiting growth of breast cancer cells. It produces an estrogen effect in the uterus, bone, liver, and coagulation system. It is used for both chemoprevention of breast cancer in those with a high risk of breast cancer, as well as adjuvant endocrine therapy in those with a history of breast cancer. One of the biggest side effects is DVT or VTE. There is also an increased incidence of endometrial hyperplasia and cancer. These risks of DVT and VTE, or thromboembolism, as well as endometrial hyperplasia and cancer, are age-related. However, the overall risk of these remains low. For example, the risk of endometrial cancer in those with tamoxifen is 4% versus 1%. Other side effects include cataracts and vasomotor symptoms. Raloxifene is also a SERM like tamoxifen. However, it is important to note specifically which tissues it acts as an antagonist or protagonist on estrogen receptors. Raloxifene is a competitive antagonist of estrogen receptors in the breast, thereby inhibiting growth of breast cancer cells. It is also an antagonist of estrogen receptors in the uterus. Similar to tamoxifen, it has estrogen effects in the bones as well as lipids. It is used for chemoprevention for breast cancer and is also FDA approved for the treatment of osteoporosis. While it may have a side effect of thromboembolism, it is not as high of a risk as tamoxifen. Other side effects include cataracts and vasomotor symptoms similar to tamoxifen. Now, how do you choose what medication to use? It is important to distinguish between chemoprevention, or preventing primary breast cancer, versus adjuvant endocrine therapy. If a patient is going to be prescribed chemoprevention, first ask, is the patient menopausal or not? If the patient is not menopausal, you can use tamoxifen. If the patient is menopausal, consider whether or not this patient has a uterus, and if so, consider using raloxifene. For adjuvant endocrine therapy, similarly ask yourself, is the patient menopausal or not? If the patient is premenopausal, again, default would be to use tamoxifen. If the patient is menopausal, do they have a normal bone mineral density? Written here as BMD. If not, use tamoxifen, because remember, aromatase inhibitors are associated with a loss of bone mineral density. If they have a normal bone mineral density, you may use either a SERM or an aromatase inhibitor. Lastly, consider what their overall VTE risk would be. If they are not at an increased risk of thromboembolism, you could use tamoxifen or aromatase inhibitor. If they are at an increased risk of VTE, consider just using aromatase inhibitor. Now, this is a very oversimplified algorithm for prescribing either SERMs or aromatase inhibitors. It is important to take into account the patient's history and their overall risk of osteoporosis, side effect profile, as well as thromboembolism risk. This summary table is courtesy of Dr. Lindsay Hoeppnner, one of our wonderful graduates. It nicely outlines the pros and cons of the SERMs, tamoxifen and raloxifene, as well as aromatase inhibitors. Going line by line, you can see the indications as well as the risks here. Tamoxifen and aromatase inhibitors, such as anastrozole, are used as adjuvant therapy for ER-positive cancers. Tamoxifen and raloxifene are used as chemoprevention of breast cancer, whereas aromatase inhibitors are not. You may see improved bone mineral density with tamoxifen and raloxifene. Tamoxifen has an improved fracture risk specifically for non-vertebral fractures, and raloxifene has an improved vertebral fracture risk. Raloxifene is also FDA approved for osteoporosis. Aromatase inhibitors do not improve bone mineral density. Conversely, they actually increase the risk of osteoporosis. Across all categories, you can see that vasomotor symptoms or hot flushes are seen in all categories. There's an increased risk of VTE or thromboembolism. However, the risk is highest with tamoxifen. Tamoxifen also has the highest risk of endometrial cancer and cataracts. One of the main side effects seen with aromatase inhibitors is joint and muscle pain. Lastly, the main distinction based on age is that tamoxifen is the only FDA-approved medication to be used premenopausal.